particularly lovely to see you.
Thank you very much indeed.
No,
I'm in
that's
good form today.
great. Well, lovely to see you, because we know it's been a tough time and you're a very valued member of the SWFT family. So lovely to see you, Michael. But we're going to get going with the Going the Extra Mile Awards, which are our celebration of individuals and teams that have literally gone the extra mile for us. So I hope we have Jareth, our patient experience administrator, on the line. Excuse me, Jareth, as I quickly try and check people who are in the meeting with us.
Yes, I'm here.
Jareth, thank you. Great to see you and hope you're keeping well. So you've won the winter individual Going the Extra Mile award. And so I thought I'd just read out your nomination, my friend. And it was providing assistance to a patient who fell on uneven surface outside the Lakin Road entrance. One of the nominators said, Jareth saw the patient fall and immediately went to help. He provided first aid, and due to the extent of the injury, he took the patient to A&E for further treatment. Jareth is a non-clinical member of staff, like me, and went above and beyond to help the patient until she was in the care of A&E. Afterwards, he reported the uneven paving to estates to avoid future falls and the accident through instant reporting. The nominator also said, Jareth is always a kind and compassionate member of staff, and the patient experience team, he never shies away from helping. This is not the first time he's provided support outside of the role as a patient experience administrator. He previously helped a different patient at the bus stop who had tripped over and ensured the bus driver waited and then helped her back on the bus. Jareth, you're an absolute exemplar of the kindness and concern for others that we celebrate in our values as a trust. And you're a very worthy winner of the Winter Individual Going the Extra Mile Award. Thank you very, very much.
Thank you.
And our team winner is a Bluebird Centre team. So lovely to see all of you. Hopefully I can see some of you on the call, but Anna Main, Emma Charles, Hannah Cam, Kate Wilford, big wave to all of you. And the Bluebird Centre is something which is, and Angie, lovely to see you as well. The Bluebird Centre is something we are rightly proud of as a trust. It's a wonderful facility to provide a special birthing experience for mums and dads who are blessed in being able to have a baby. So you're the Winter Going the Extra Mile Award winners. It goes out to all of the team, and you were nominated by a member of staff for going above and beyond for a family having their second baby on Christmas Eve. The nominator wrote, sadly, the woman's husband had been diagnosed with stage 4 terminal cancer in the previous August, and he'd spent the last few months in and out of hospices, and undergoing various treatments and surgeries. He was very open with the team about his diagnosis and treatments, and the team spent a great deal of time photo taking, chatting, laughing, and shedding tears with them throughout the day. He shared that there is a strong possibility it will be his last Christmas, and their focus as a family was on making as many memories as they could whilst continuing treatment for as long as he felt able to. The nominated team members went above and beyond to make their Christmas Day special. They cleaned up the family room in Bluebell, printed and laminated special Christmas dinner placemats, set and decorated the table, and brought the Christmas tree through from the hallway to make it extra festive. They ordered the mum a Christmas dinner from the kitchen and sourced the husband a special pureed meal, as he is on a strict puree-only diet, so they could both enjoy Christmas dinner on Christmas Day. The nominator finished off by saying the amount of thought and effort the team had gone to make the day special for this family Christmas, to help them make the memories they were keen to do. The family was so appreciative. What a lovely, lovely story. And I know there are many others. And it does bring together the two themes. Many of you will have heard me say the most important thing we do as a trust is to bring life safely into this world and to allow life to leave the world with dignity. Team, you're wonderful exemplars of that philosophy. Thank you very, very much. And please take back our love to the rest of the midwifery, neonates and all of the team, because we know day in, day out you do phenomenal stuff and we're very grateful. And I know the citizens of Warwickshire are as well. So with all that good stuff out of the way, we'll now get on to the necessary stuff of governance. It's a still very tough time for the Trust. We'll touch on some of the performance metrics. In summary, we are still amongst the very best performers in the NHS, but we are not performing to the standard that historically we would like to perform to, and that is very much our focus. As ever, the money's very difficult, but the team under Glenn stewardship is doing still quite remarkable things. This morning we had a great presentation from the Community Recovery Service, which is a really important initiative that we've undertaken as part of our community integrator work, which is leading in terms of providing therapy and support to allow individuals who otherwise would be stuck in hospital to get home quickly and to be able to be re-enabled to get back to this, their best life outcomes as possible. Really, really good stuff. So thank you very much for everyone involved in that community recovery service. We also talked about the staff survey and some important improvements there, which we are embargoed to talk about, but just to say that as a board, whilst we've still got work to do, we're very pleased with the results. We talked about the new EPR system, which is hopefully going to be launched in UHCW in June, and they've got our full support in that, and that will lead to inevitable decisions for us. And finally, we talked about things we need to do financially to make all the numbers add up, which is increasingly difficult for us. But in the way we've done historically over the last, I think, 12 years now that we've made break even or better, we've come up with some innovative ideas, which we do need support on, particularly from Council of Governors, but we've got some ideas to break even, hopefully, for next year as well. So that's what we've been doing. We have apologies for absence from Fiona Burton and Bhaskar. Any new declarations of interest? Could you please raise a digital hand, please? Sarah.
Sorry, can we just go back to apologies, Russell? We've also got apologies from Pramjit and Yasmin.
Thank you very much, Sarah. And Yasmin, if you're watching this digitally, our thoughts are with you at the moment. Any new declarations of interest, colleagues? Okay, I can't see any digital hands raised. So the minutes of the meeting held on the 6th of December. Can you please raise a digital hand if you had any problems with the accuracy of those minutes, please? Okay, I can't see any hands being raised, so I'll take those as an accurate record. So we'll move then to the action points arising, which are on page 14 of, once again, a very substantial board pack. The first is with respect to the integrated performance report and Gertie to request the data team incorporate vacancy figures. That's now been done. Thank you, Gertie. Gertie also to ensure outcome of the equality delivery system gap analysis to be presented to the foundation group in February. That was done. Thank you. And then on the Elva, congratulations, Elva, I think on a new baby, to send Ollie Hisco information on the update of employee assistance programme. That was done. And then Sarah to ensure the signature on the minutes on clinical governance were amended, and that was done as well. And then there's one which is ongoing, which is Fiona to include data on intelligence conveyancing in future reports, and that's in progress, so we'll keep briefed on that. Do colleagues feel there are any minutes that I have missed or actions arising? Okie dokie. So we'll move on then to the minutes of the Foundation Group board meeting on the 7th of February. Now, for members of the public who haven't been to those, I would thoroughly recommend coming along. It's where we now get the four constituent parts of the Foundation Group together and do a compare and contrast on certain issues. And again, our February meeting, I think, was very fruitful. But for SWFT colleagues, were there any issues you had on the accuracy of those minutes? Okay, I can't see a digital hand raised. Adam, can I ask you to go on to mute for me? And so we'll accept those, and then the action points, I think, are all in hand, and we'll come back to those in the May meeting of the four board Foundation Group. I've done my chairman's remarks, which I think is the next thing on the agenda. Lots of work going on. Absolutely delighted that Sue Noyes has become the chair of UHCW. Now, Sue, we wish you well in the role. Our relationship with UHCW is incredibly important to both us here at SWFT, but also George Elliott, but most importantly to all of our citizens who rely on your tertiary services in their time of need. So we wish you well, Sue. We'll move on then to the board schedule of business. So Sarah.
Thank you, Russell. So this maps out the business that the board should expect to see during 24-25, can be varied at any time as required. The eagle eyes of you will notice that the 7-day working annual compliance report I've actually got ticked for April and March. It should just be scheduled for March, so that will be amended on the final version. So happy to take any questions, and it's for the board's approval, please.
Thank you, Sarah. Always a bit tragic when you see your life being planned out for the next sort of year ahead. Any questions or perspectives on the schedule of business? Okay, if you're not happy to approve, please raise a digital hand. Duly approved, thank you. Then we've got the standing orders. Again, Sarah, back with you.
Thank you. So this has been through the audit committee, and we're proposing no changes to the board standing orders. It's for the board's approval and then on to the Council of Governors in May for ratification. Thank you.
Thank you, Sarah. Any questions on the Board of Directors standing orders? Please raise a digital hand. Okay, can't see a hand raised. If you're not happy to approve, therefore, could you please raise a digital hand? Duly approved as well. Thank you, Sarah. And then we're on to the annual review of policy review group terms of reference. Adam.
Thank you, Chair. There are no major updates. It's part of the annual review, so some job titles have been updated, but nothing substantive.
Okay, thanks. Any questions on those from colleagues? Again, this is for approval. If you're not happy to approve, please raise a digital hand. Duly approved. And then we're on to the final trust. Don't think you and I could become Chair and Chief Executive anymore. The final trust annual objectives for 24-25, including the view of trust strategy. Glenn?
Yeah, thank you, Russell. So these are final because they've been to us previously in draft form, so I won't go through them in any great detail, but just to emphasise a couple of points. So firstly, having reviewed the strategy, we've made the decision not to move away from the 5 big moves, but to bring a couple of them together. So the supporting domiciliary care and the home first are coming together into one big move, and it becomes an even bigger move and an important move as a consequence of that. We, as you said earlier, Chairman, we spent some time in workshop this morning looking at the community recovery service, which is a national pilot, which is helping to prove how important it is to ensure that we do left shift activity into non-acute settings. We also put quite a bit of emphasis in this year's objectives around productivity. And anyone who's seen a bit of the budget over lunchtime will realise that that was time well spent, because there is quite a lot of emphasis now on productivity in the NHS. Productivity is usually a code for you're not getting any more money, so you need to look at productivity. So we've been doing that as a group. and actually have the ability to share best practice across the group. But you'll see that featuring in here quite a bit. Otherwise, a number of areas here that you would expect to see linked to the big moves, but also linked to some of the local priorities. I think, Sophie, you wanted to add a little bit of emphasis on a point. Do you want to come in now?
Yeah, thank you. So we held, in a draft format, we held a meeting with our divisional leadership teams for them to start thinking about what this means for the divisions. As part of that conversation, we felt there was an enabler missing, which is around ensuring there is capacity for care to be delivered in the right place. So that idea that actually it's not all the front door, that we need to start thinking further down the pathway. So the divisional leadership teams were keen for us to add that as an enabler, if we can add that in for approval today.
Okay, that all sounds very sensible. Any questions or perspectives to Glenn or Sophie? So that slight amendment Sophie's referred to, if you're not happy to approve the annual objectives, could you please raise a digital hand? Okay, duly approved. Thank you, Sophie, for all the work that I know goes on, and Jenny does a great job, I know, behind the scenes supporting you. So thank you for all of that. So we then move on to the patient safety incident response framework, which Ellie, you're going to brief us on, but this is obviously moved. This is a new initiative, a much more learning focused initiative. Over to you.
So I'm hoping that Christopher Day is about to join, and there he is, just on time. And he is going to take us through.
Hi, Christopher.
Hi there. Are you ready for me to talk to the PSWFT policy?
Do you know, Christopher, we are.
Super. Okay. So this is a fairly templated policy that arose from the change from the serious incident framework to the patient safety incident response framework. So it's a national framework change for managing incidents brought out by NHS England. And as part of that, there's a requirement by NHS England that every trust has to have a patient safety incident response policy. And to aid with that, they created a template that every trust has to follow. So the policy you see in front of you is going to be similar to nearly every trust in the country. 80 to 85% of the text that's in that policy was provided and is mandated by NHS England, but there were sections within that template that allowed trusts to add any localised text for how they intend to localise incident management within the trust, and that's effectively what you see before you. So the policy is largely written for us, but we have added text where we've been able to. The draft policy has been approved by the Integrated Care Board, who've been monitoring and getting assurance of our development through the whole PSWFT process. So they've seen and approved it. It's been approved by Policy Review Group, and it's been approved by Patient Safety Surveillance Committee and Clinical Governance Committee. But one of the requirements is that board are cited to the policy. So we thought we would bring it here as well.
That's great. Thank you, Christopher. And it's for members of the public, the PSWFT approach is far more learning focused. So that unfortunately, mistakes do happen in the healthcare system. The key thing is not to allow them to continue to happen. And this whole new framework and policy approach really helps engender a more open learning philosophy. Any questions or perspectives to Christopher or Ellie? Okay, well, at one level we have to do this, but like I said, I think it's a very good thing to do. If you're not happy to approve, please raise a digital hand. Christopher, thank you for the work you've been doing behind the scenes on this important stuff, and through Fiona, Ellie and Charles and Bhaskar, we look forward to hearing how things work going forward. So thank you very much, Christopher.
Thank you, Chair. Thank you all.
So we then move on to the performance review and assurance bit of our board. And the highlight for many of us is the Chief Executive's overview. So Glenn, How are you seeing things in these interesting times?
Don't oversell that at this point in the agenda, Chairman. I'll start with a couple of frustrations, actually. So firstly, I'm frustrated about something really positive, which is the staff survey that you alluded to earlier. It's embargoed. It comes out tomorrow. It's great from a SWFT perspective. Great in terms of what it means for our patients, the engagement and the innovation of our staff, but also for us in a difficult recruitment market that we continue to demonstrate we're an organisation that people want to come and work for and like working here when they do. And so even though I can't talk about the specific results, I think tomorrow the embargo will be lifted and we'll see where we are in terms of hopefully ranking as one of the best organisations in the NHS in that regard. So that's a really positive one. Secondly, a frustration that isn't positive, which is around the Badger project. Firstly, it's a great project, and the building is coming together really, really well. The work we're doing with the Stour Partnership actually in bringing that building to life is fantastic. But there's a frustration recorded here around the situation we've reached with the League of Friends, who at the moment, it looks like we can't access the funding that has been given to the League of Friends for the hospital because they are insisting that beds are in the new hospital, which isn't our design and our model and our strategy. So we'll talk about this later in our confidential section of the board, but it makes it hard for them to continue to be our League of Friends if we can't access the funding. The A&E performance target, so we're in March, and in last year's planning guidance, one of the milestones associated with A&E performance was to move to a 76% 4-hour wait standard, and we've been putting a lot, and I'm sure Mahakama will talk about this at length later, we've been putting a lot of improvements into place right across the system, including the one we talked about earlier, actually, the community response arrangements. But they've also announced recently that there will be capital incentives linked to this performance. So if we can deliver better than 76%, there's a range of things that could potentially lead to the organisation getting more capital. Now, we would want to deliver more than 76% for our patients because it's the right thing to do, but it's always nice to have a capital incentive. So we'll give a bit of an update on that later. I think it's even more remarkable when you see where we are from a performance perspective, when you look at what I also refer to in the second paragraph there, which is the increasing demand, the increasing number of ambulance conveyances from Birmingham and from Coventry. So despite all of that, and yesterday we had another day where we had 320 plus attendances. So it's, demand is high, but we are delivering great outcomes and access times for our patients, which is something we should all be very proud of. And as we test some of those things during this month, we'll be taking a view as to which of them can be continued into next year. Obviously, there's a bit of a constraint around that, around funding, which takes me on to the planning guidance, and it's budget day. And I refer here to the fact that we've not had any planning guidance for the year, which starts in a few days' time. As we understand it later today, the planning guidance for the NHS will be officially published, linked to the budget announcements, but I've already referenced that. What I haven't seen so far is any particularly new funding allocations for the NHS alongside the planning guidance. So it will be a tough year, and we will be working hard, as you said earlier, Chairman, to try and ensure that we can balance our budget. That is dependent on income discussions with our integrated care system and those around us relating to some of those demand changes. But we will also be working through all cost pressures, looking at all opportunities for improvement and productivity increases linked to the objectives we talked about earlier. A slightly related issue, the Children's Services contract. Our local authority colleagues are under a lot of financial pressure also. And what I refer to here is the 0 to 5 years contract, which is commissioned by a local authority in Warwickshire. And we also provide the same service into Coventry and into Solihull. We are having to ensure that we can fit the service within the resources that are available, and that's something that we're looking at very closely through planning. At the moment, the direct costs of the service are more than the income that we receive. So we will be firstly seeing if there's a way around that with other system income, but also if there isn't, to make sure that we are operating within the resources that we have. I then refer to the community integrated contract. I won't go through all of that. We've talked about that before, but obviously the importance of SWFT being in lead provider role for the whole of Warwickshire will be an important thing to show that we can pull that off and work with our partner organisations. I refer to UHCW and George Eliot here, but also all the other players in the system, particularly primary care and social care. I then referenced the further action, which only finished last week, from junior doctors. There still isn't a resolution to that dispute, and it will be harming patients because any delay to treatment leads to patient harm. So without taking any sides on that, we do need to ensure that there is a resolution to that, because we don't want our patient care to be compromised any further. However, what I would say is all the clinical staff who have helped to provide cover, all the managers who helped to arrange that, have done a tremendous job. And so we've managed as best as we can to maintain business as usual throughout all of these strikes, but it's something that should not be business as usual. There's then at Appendix A an update from Coventry Warwickshire ICB. More from our great teams, talks there about the Innovate Healthcare Services, which is an arm's length company providing IT back to us and George Eliot. Then I referenced the Going the Extra Mile Award winners and the visits from directors to various wards and departments within the organisation. So I'm happy to take any questions on any of that.
Thank you, Glenn. Any questions or perspectives to Glenn? Ollie?
Sorry, this is probably going to sound a little bit pedantic as a point of accuracy, but on the visits from Board of Directors, I attended 4 of them, and I think you've got my namesake Oliver listed down for all 4 of them.
Okay, too many Ollies or Olivers.
We will make sure that's corrected.
Okay.
Thank you.
Any other questions or perspectives to Glenn? I think the only other thing I'd add, Glenn, is, the other challenge which we have had, and I know it's been a particular challenge for our ED department, has been people who are emotionally going through a very tough time, and ideally would be being looked after by our partners in the system when they're having a mental health episode, spending an inordinate amount of time in our ED. I'm conscious of the fact we've had 2 individuals spending over a week in our ED because they weren't able to get a mental health bed. I'd just like to put on record our thanks to our ED teams for looking after patients who, really shouldn't be with us, but they still provide a very high level of care in very stressful circumstances. So thank you. Okay, if there are no other questions to Glenn, we'll move on then to the integrated performance report. Adam.
Thank you, Russell. So important to note, I think, at this point, that this report reflects January, and January is always the most challenging month for the Trust and the NHS as a whole, as we see high attendances from seasonal illnesses, and the high levels of emergency activity clearly create pressures on our beds and across the organisation. This year, Glenn mentioned the industrial action. The challenges in January were clearly exacerbated by a period of national industrial action at the start of the month, and I think we need to commend our teams for how they managed those. Our approach to winter is very focused on the whole organisation rather than the emergency department itself. Recognising flow across the hospital is critical, and so the work of our fantastic community teams and partners is critical to that. And we mentioned the community recovery service. I think we can see that in the performance reports and the good performance of our community teams, and the work that's been done across the organisation. And I think while our emergency performance dipped slightly in January, it still compares favourably nationally, and is significantly better than the same period last year. So I think it's important to acknowledge we're not where we want to be, but I think the hard work that's gone in despite the pressures, it has to be acknowledged. I think it's also very positive that despite the pressures we've seen across the organisation, we've managed to keep really high levels of elective activity up, and our focus therefore on reducing waiting lists. And again, we need to commend our teams for that. While we are under these very high demand pressures, I think our focus on quality of services is more important than ever, and the report contains some really important headlines on this. So while acknowledging the ED waits are longer than we would have liked, the focus for us has been on the well-being of those waiting. So, for example, we're providing meals to those who have a long wait in ED. It's also really encouraging to see from the report that we have the highest level of uptake of feedback in an emergency department nationally over the last quarter, and that feedback is positive. In fact, our trust-wide patient feedback has significantly increased since introducing text messaging feedback, and we saw 89% positive feedback during the last quarter, which is really reassuring. I think finally it's important to mention the finances. So the CFO will discuss financial performance in more detail, but it's fair to say it remains a challenge. The report does reflect periods of additional industrial action, and I think we've had more information on funding to support those now. Encouragingly, despite the financial pressures, we have seen sustained progress in our reduction of agency spend, which has been supported by a really sustained piece of work to recruit and retain staff, and has seen our substantive vacancy numbers reduce. And I think this needs to remain a focus as we go into next year. So those are my highlights, but I will hand over to my colleagues for the more detailed summaries.
Okay, that's great. And if colleagues are okay, we'll move into the detail and ask questions on each specific area. So I started off on quality and safety. Charles and Ellie.
Thank you. So as Adam has highlighted, we're really proud of our friends and family feedback. We value and welcome patient and service user feedback, and the more we get, the more it helps us to make improvements in our quality and our services. So that's very positive. We're going to continue to move forward and try and make that data more accessible in real time to ward managers, which will help with them responding to it. VTE, we've highlighted, we have had issues with compliance with VTE assessments. We are now looking like we're getting back on track after some targeted work around that, but it is worth highlighting that despite concerns about the assessment previously, the actual number of people being readmitted with a VTE event is very, very low, which is assuring around the fact that people are clearly getting the correct preventative treatment. And then finally, just to highlight Chris Day, who's talked us through the PSERV policy, and with our pressure ulcers, we are working through what that will look like in terms of prevention of pressure ulcers and supporting and learning staff, moving away from our old RCA action plan type model to a swarm approach, and learning and joining up learning and not repeating action plans. So that's very positive as well.
Thanks, Ellie. And Charles, anything you want to add?
Just an overall comment that you know, the fact that these indicators have improved or stayed where they should be in the light of really unprecedented activity. You know, every day the clinical teams are climbing a mountain to deal with the amount of work that's coming through the door. We've got, you know, record attendance as ED and recovering elective work. So I think that the workforce deserves a really big thank you for actually what they're doing and their engagement, you know, to come back and do it again day after day. And I'd add that to, you know, that it's everybody in the trust that's working to achieve that.
No, absolutely well said, Charles. And it was good this morning. We had Health Watch Warwickshire with us at the board workshop, giving us their feedback on the citizens' experience of the hospital, which was pleasingly positive. Any questions to Ellie or Charles? Okay, can't see any hands raised. So thank you, Ellie and Charles. And we'll move on then to Harkamel. Harkamel, operationally, very tough. How are you seeing things?
Thank you. So yeah, January was a tough month. So we didn't hit 76% standard, but it was our first month where we actually improved month on month. So we did do better than December. And soon I'll be able to tell you that we did better in February and we actually did hit the standard. But you'll have to indulge me again because it's brilliant news and I'm really, really, really proud of the progress that the team are making. In terms of January, it was a really, really busy month. So our average attendances did increase in January and then were above the year-to-date average. And then when you look at some of that demand, driving like that performance was really challenging. And we did have, very sadly, patients who were in our department for over 12 hours. The majority of those patients were patients who were waiting for mental health beds, as well as some flow challenges that we had. But actually, it was 2.7% of our attendances waited over 12 hours. And when you look at last year, that's down from 6.3%. So I'm really pleased to be able to say that despite significantly higher volumes, we have managed to maintain control on that. From an elective perspective, January was just an exceptional month. We started off with a strike. There's obviously lots of planning that goes into elective all the time, but especially in January, it's really challenging to work around patients' availability and making sure that we can plan those patients in effectively. But with winter pressures and the strike, we managed to deliver 114% of our baseline, which is just staggering. And I'm so proud of the team, and it's just lovely to be able to share that with everybody. That did improve our RTT a little bit as well. So we continue to try and tackle our long waiters and are on track to deliver no patient waiting over 78 weeks. But sadly, we will have some patients waiting at 65 weeks, and those patients are orthodontic patients. I've shared, perhaps quite a few months ago, concerns around orthodontics in terms of them making up the bulk of our long waiters, and that pressure remains. So we have sought support from NHS England. So NHS England and our ICB are working with us to try and provide support for those patients, because we just don't have the capacity internally to be able to see and treat these patients. This is a national problem. Incidentally, our waiting times are better than some. So when we did request mutual aid, we ended up with the converse effect where patients asked, other organisations asked us for support. So I think that just gives everyone a bit of an indication of how challenged orthodontics is nationally. My other concern is around diagnostics. So we are still really struggling with non-obstetric ultrasound. We have taken a paper to our management board, and we do have an action plan in place. It's just a work in process and progress, and that will have a lead in time to improvement. And just to say once again that cancer demand does remain high and is a challenge for us. So whilst we did deliver 28-day fast diagnosis for December, January, as expected, will be a challenge in terms of when that performance is validated and comes out, but we are still on track to achieve the faster diagnosis standard for cancer. I have put in a bit of a deep dive on ambulance handovers. So we've talked about this a little bit before from a risk perspective, in that I think it was Fiona who shared her concern around the level of, we call it intelligent conveyancing or ambulance conveyancing from other areas. So when other parts of the system are under pressure, or other parts of the region, often our ambulance service will look to sites and see where ambulances can be sent to try and ease some of the pressure. And that prompted me to put this paper in place, because I just wanted everyone to understand some of the demand that we're facing here. So our ambulance attendances have actually hit new highs. Other organisations are not seeing the same level of ambulance demand. For us, it is increasing. And you'll see from the graph that the out of area pressure does remain. And that's really challenging. So we are working really closely with our ambulance colleagues and our system colleagues just to make sure that we are getting patients who are appropriate and we can facilitate discharges quite easily. So, for example, if you get very elderly members, very elderly patients, repatriating those patients to out of area can be really challenging, and then you end up with a much longer length of stay. And often these patients are quite elderly. So, you know, I'll give the example of a patient who was over 100 years old. Her children were 80 and they couldn't drive here to visit her, and then we couldn't get her back. And actually, that's a really poor experience all around. And she should never have been here in the first place. And you know, and she died here. And that's absolutely not the outcome that we want to see. It was you know, not what we wanted for her, and just awful then for her children, who we were trying to liaise with and kind of and work with, so that, you know, the patient had a good death with us. So just against the backdrop of that, I wanted to explain some of the actions that we are taking. So I've included that risk, but what I will say is that we are logging those incidents, and I'm really grateful to Charles and Fiona for their support in terms of leading that work with colleagues from a clinical safety perspective, because I think that's really important. But we also have put in a number of actions to improve our ambulance handover times. And Glenn alluded to the winter incentive scheme. And as part of that, we are looking to achieve above 76% for the 4-hour standard, but also to have minimal patients waiting over half an hour to be offloaded from an ambulance. And I think what you'll see is actually we are improving, and generally we benchmark quite well on that. In terms of the actions, it is a whole system approach. You can't offload an ambulance unless you have flow. You know, the whole hospital has to be flowing effectively in order to meet both those standards. So Adam briefly talked to what our winter approach is, but just to sort of reiterate, our focus is very much on lots of schemes. It is not just ED focused, it's absolutely out of hospital, it's elective, it's same day emergency care. It's really important that the whole organisation gets behind us. And I think some of the proof of that is in the pudding that we're eating at the moment, as it were, because we did improve in January, we did improve in February, and we are working really hard to maintain improvements in March as well. And it was just to sort of build on Charles's point that I'm very grateful to all of our teams. We couldn't do this without absolutely everyone. There's admin and clerical, medical nursing, our therapy teams have just been impeccable. Our porters are incredibly responsive, and just to sort of finish on that note, that whilst we're under pressure, we still keep going. And thank you.
Thank you, Harkamel, and that ambulance conveyancing analysis was very helpful, Glenn.
All of which, Harkamel, will be reflected in those standard survey results when we see them tomorrow. I just wanted to thank you for what you do on this, but also for bringing just that human story about ambulance handover delays, because I think that helps to reinforce what this is about delivering compassionate care, not just moving the ambulance to the quietest A&E or the most efficient A&E in our case. The other thing I just wanted to pick out was the point you raised about the orthodontics waiting times. It is a national problem, and that's one of the reasons why it's become a local problem for us, because there used to be more services around us, and so it's not about poor planning on our part. We find ourselves in a situation where we're delivering orthodontics to a much bigger footprint than just South Warwickshire. And that's what's causing us big concern, because a lot of other providers have stopped providing that service. So well done for maintaining that below 78 weeks, but it remains our most challenging specialty in terms of long waits.
Yeah, no, absolutely. Ollie?
Yeah, firstly, I think the metrics are really good, and it's always good, especially the context to have with the benchmarking. Just given the article and the investigation in the BBC in the 19th of February around hidden waiting times, I guess my question is, do we have a handle on waiting times that sit outside our metrics? Do we feel that we understand them well?
Yeah, so we have a monthly performance board, and we never stand that down. So even during winter pressures, we always keep that going. And as well as all of the reportable standards, so, you know, the referral to treatment 18 weeks, we talk about all the patients who are overdue a follow-up or might be on a therapy waiting list. And we are continuing to make sure that we're refining that as much as possible so that it's easy to digest, but absolutely we're cited on all of those metrics. Because, you know, invariably, those patients are the ones who will come to harm if we don't spot them, or, you know, they'll come through ED and add pressure in a different way.
Great, thank you.
Thanks, Solly. And any other questions or perspectives? I will take forward with systems colleagues, because it is an increasing concern of mine when I go to system meetings that I don't see either representation from primary care in the way we used to in the old CCG world, and certainly not from the ambulance service. And I do think those two big stakeholders need to be part of the system discussions that are occurring for all of the reasons you've just referred to. But our heart goes out, as Glenn said, to that family of the 100-year-old patient and their circumstances. That clearly is not what the National Health Service wants the experience to be at end of life. Harkeman, thank you for your hard work and leadership of the teams. We'll move on then to workforce, and Gertie, over to you.
Thank you, Chair. I'll take the report as read. I'll just pull out a few key points. We continue to see improvements in our time to hire, which is really positive. We're streamlining and trying to make recruitment as efficient as possible, conscious that we are in a very challenged market. So the better experience we can offer our colleagues as they join us, the more likely they are to come and work with us. We have unfortunately seen an increase in the sickness absence rates over December. This is a usual seasonal variation with increases in cough, colds and flus. Turnover is continuing to decrease, so it's moving in the right direction. We've seen another slight decrease again in month. Our appraisal rates are now above 85%, which is really positive and a real reflection of the great work that our divisional colleagues have been doing in terms of undertaking these really important health and wellbeing conversations and developmental discussions with their members of staff and getting them recorded. There are still some hotspot areas and we're continuing to provide specific focus around them. I'll just pull out, as Adam has, that recruitment continues to be one of our greatest risks in the organisation, and we are seeing the numbers in terms of both recruitment for nurses and our clinical support workers moving in a downward trend, so that we are seeing less vacancies. We do still have a lot of work to do in that, and obviously there's a number of focused recruitment events taking place across areas like the emergency department, theatres, community health visiting, cardiology and so on. I'll leave it with that, Chair, but happy to take any questions.
Thank you very much, Gertie. Any questions or perspectives to Gertie? And Gertie, members of the public may not have been at the George Eliot board yesterday, but we had a wonderful presentation from our international nurse recruitment team, talking to a number of our colleagues who have joined us from abroad, and some really great work going on at George Eliot. Are we maximising the cross-pollination of experience and ideas on international nurse recruitment between George Eliot and SWFT?
Yes, Russell, we absolutely are. We equally have an absolutely wonderful programme of international nurse recruitment at South Warwickshire, a really, really fantastic supportive team of pastoral care, and that sits with Ellie and Fiona's team. And Harkmal and I actually had a conversation yesterday in between the boards where I said it would be really positive to bring an equivalent story to the SWFT board workshop in future, because we have a wonderful cohort of international nurses and such a fantastic breadth of support for them, and we do work closely across the education teams and the practice education development to make sure we're maximising the support. Thank you, Chair.
Thank you, Gertie, and I'd just like to put on record my thanks to those who do come from abroad to work in the NHS and the families they leave at home. We talked yesterday about the enormous levels of homesickness which understandably colleagues feel, but also families back home will be missing them. So we really appreciate the sacrifices made to work in the NHS. So if there are no other points to Gertie, we'll move on then to Kim. We're just a few weeks away, as Glenn indicated, from the year end. Kim, how are we doing?
Thank you, Chair. So this is the report covering the January position, which reports a £3.4 million year-to-date deficit. That does include costs for industrial action related to December and January. So if we excluded that, which is about £1.2 million, then we were pretty much on trajectory to deliver the break-even position that we had recommitted to back in November. So that's the situation. We have recently just found out that we have been given a figure of 1.5 million to compensate us for strike action for December, January, and an estimation for February. We've yet to finalise the February year-end month-end position, so we're not sure whether or not that is enough really to cover our costs year to date. The key thing is that we were already absorbing, a 1.6 million pound shortfall actually. In relation to the first 6 months of strike action, or already to deliver a break-even position. So the fact that we're still saying at the moment that we're forecasting a break-even, parking the further strike action, I think is a significant achievement for the organisation. So we are still we're obviously looking to see if we can manage really the further mitigation of the February strikes once the month 11 position comes out. And clearly, we don't know around where we're at in terms of year end at the moment. As Harcombe has alluded to, operationally, it's very challenging at the moment. We're putting in a number of schemes to obviously deliver the ED performance, and that obviously has a cost attached to it. So inevitably, we always work together to ensure that we're managing the money as well as making sure that we're putting it in safe staffing really to manage the patients. So hand in hand, we work together to ensure that we manage the financial position. Agency, as Adam has already alluded to, we have seen a month-on-month decrease in terms of our run rate on an agency expenditure, which I think is really positive. So if we compare it to the same period last year, we are spending 1.6 million pound less agency spend compared to the same period last year. So that's a significant reduction. It's a testament really to the work really that the teams have been working on in terms of managing our agencies. But there's still work to be done on that moving forward, and that would obviously feed into our Excel in Everything programme into next year, along with our productivity work programmes as well. Other things I want to draw attention to is that we've got some capital slippage. The report talks about the capital slippage, and we've got a methodology to mitigate that and to manage that and carry that forward into next year, so we don't lose any of our capital funding. So we will have further discussions on that in our confidential board discussions. And the final thing I wanted to say really was, as I said, I've taken the board through workshop in terms of our high level draft plan figures for next year, and that's for further discussion in confidential session later on today. But clearly we're working with in envelopes that were given to us more than a year ago, and in the absence of any final planning guidance, so very much draft plans for where there's further work to be done. Happy to take questions.
Thank you, Kim. Oh, for the days of PBR, where the more work we did, the more we got paid in a very clear fashion. Glenn?
Yeah, thanks, Kim. It would be, I think we do need to push ourselves a little bit harder on the agency reduction position. If you look at the positive moves on recruitment, and hopefully with sickness maintained at a reasonable level, you look back on a number of years on that chart, and we need to challenge ourselves to get back to those levels. I think it would be helpful, Kim, if we could just have the key to that chart so we can understand the different colours on it. Because whatever we've done with yellow on that chart, we need to do with blue and orange too.
Yeah, I think, sorry, the key must have dropped off. The yellow would be the nursing, and the blue would be the medics, I think. So but I'll make sure it's obviously just dropped off in our narrative somewhere. Okay.
I don't think it is. I think it's another staff group. But yeah, if we could add it, it'd be helpful.
Thanks, Glenn. Any other questions to Kim? Okay, I would just make a general plea, and I know Glenn does an awful lot behind the scenes. There is a real focus, which again was mentioned in today's budget, in productivity in the NHS. One of the things I'm most proud of this team, and in fact across the foundation group, is we've been focusing on productivity for a number of years, but having transparent incentives which encourage increased productivity and increased activity would, in my opinion, make life much easier for everyone, and would indeed deliver the productivity which essentially we're looking for. We'll move on then, if there's no other questions, to Kim on to the quality safe staffing report. And Ellie, over to you.
Thank you. So appreciating this is a very long paper, as it's now a quarterly report and we have 3 months worth of data for all the wards and departments. So what's important about this is that we now triangulate our data, so it's not just about staffing figures, it's also about looking at our quality metrics in relation to that. So overall, it's as has been mentioned previously, we are seeing a reduction in vacancies with a corresponding reduction in agency spend, some improvement in retention, and that is in credit to all the divisions really working hard on this, and our colleagues in people and workforce recruitment and well-being, and all those work streams coming together. We are still seeing some challenges in some of our speciality areas, such as paediatrics and our community children's team, which is a difficult area to recruit into due to national shortages, but obviously remains an area of high demand. Maternity services have done particularly well with their recruitment and retention. Nationally, some areas are struggling to recruit and retain their midwives, and we are often at 0 vacancies and have people waiting to come here. So that is a credit to our maternity services. Just to note, as has been mentioned, we do appear sometimes to be overstaffed. That will be either because we are looking after patients with a mental health need and we're having to have additional registered mental health nurses to do that above the ward template, or if we do put in any extra capacity or additional beds, we always increase our staffing to keep everybody safe and to support the staff in those areas. Some of our turnover is due to our own success as in our talent management. So we are growing a lot of our own staff with trainee nurse associates, virtually all of whom, I think it's 90-something%, remain with the organisation on qualifying, which is really helpful. And so a lot of those are now going on to do their registered nurse training. And again, they will all be our future workforce. So as I say, mindful it is a very long report, but I'm happy to take any questions.
That's great, thank you. Ellie, any questions or perspectives to Ellie? Ellie, it may be a combination of your team and Kim's team, but I would like for it to be transparent, because I know it's happening more and more often where we're having to get expensive agency mental health nursing support in to look after certain patients, that we transparently show what that number is each month, because I think it will be a surprisingly big number when you add it up month after month after month.
Yes, thank you. We've got finance starting to look at that for us, Russell, and they've been reviewing the last 6 months costs. Okay. So
and Kim, roughly, do we have an idea yet what it's looking like?
Sorry, I don't recall off the top of my head. Sorry, I can get back to you, Russell.
No worries.
I don't want to get the figure wrong.
No worries. Kim, Glenn?
Yeah, I think it's a really important point. And there's one of the things that we will be discussing with ICS colleagues is whether we can access some of the set aside mental health funding that sometimes actually goes unspent to pay for these extra staff that are looking after those patients who are in our facilities. So that's something we will push on.
Yeah, I mean, the frustrating thing for everyone is we know our partners who look after people who are having mental health episodes are doing everything they can, but we typically have to get agency staff in who are at least twice as expensive as a full-time member of staff. So it really is money lost or wasted in the system. But certainly we should transparently talk about that number and try and recover it, as you've indicated, Glenn. Ellie, did you want to come back in on that?
Yeah, so just to say that as a without any much detail behind it, but I was given a figure of, I think it was £283,000 for 6 months from June to December last year for registered mental health nurses, of which about 168,000 was for our paediatric patients who are waiting a tier 4 or mental health bed or placement.
Blimey, that's a big number, isn't it? So you annualise that, it's at least 500,000. That's a big number. Ellie, thank you very much. Kim, look forward to the final numbers, but I think for members of the public, us being just able to communicate what the number is important, because it's a cost we're incurring, makes our break-even challenge even more of a challenge, and isn't very fair for us to be incurring the cost, let alone the impact on our operational teams. And I do know, and I do thank teams on McGregor, teams in ED, who have to cope with, or at the front line, if you like, of having to cope with patients who are in turmoil. And we last week had a nightmare situation of a poor patient who was on the roof of the ED department, and we ended up having to close the access roads and cause lots of inconvenience. This, the acute is not the setting for people who need mental health support. Okay, we'll move on then. Thank you, Ellie, for your brevity on going through that. So we move on then to the maternity governance report, celebrating the Bluebell team earlier on. Lorraine, things are getting busier and busier in terms of babies, given all of the building work and new houses around us. How are you seeing things?
Yeah, absolutely. Thank you, Chair. So I'll take the report as read. This is Q3, so that's up to December 23. So as we've said, births in that quarter exceeded all our expectations. So we had 3 months where we exceeded over 300 births. So huge thanks to our teams who work consistently through quite capacity pressures and doctor strikes to ensure the best outcomes for our women and babies. So we've been doing a lot of work actually looking, projecting forward what our births are going to be like, but also looking back at what we've been up to. And we can see that in the last 6 months, we've had a sustained increase in birth numbers, accumulating to 1,750 births in that 6 months, and a total year of 3,306 births, which is the highest number we've seen at SWFT ever. We believe this has contributed to an increase in our planned and unplanned cesarean section rates. We know our diabetic mothers numbers and referrals have increased, and that goes along with our cesarean section rates. We also note that our out of area referrals from women who want to come and birth at Warwick has increased by 30%. Looking forward, our predicted births up to July 24 demonstrate that our birth rate will continue to increase, putting further strain on our service and capacity. So we are therefore carrying out a detailed quality impact assessment and maternity options paper to consider the significant growth in every area of maternity. We're also seeking support from the West Midlands Perinatal Network, LMNS, around modelling future services, because actually as a level 1 service, we do refer into services like, for example, fetal medicine. And they're really struggling with the capacity as well. So actually this has got to be a bit of a system work, as well as looking at our birth numbers, but actually how is that impacting on births across the system. Because we've been so busy, we have actually seen an increase in our babies being readmitted to Swan Ward, and we've been doing a deep dive into that, and we believe the increase in birth numbers is because of the early discharges. So pressure for beds means that we're having to send mums and then their babies home earlier than we want to relieve the capacity, and obviously then those babies having to come back in. So we're doing a lot of work around feeding support and looking at the reasons for readmission. We're also doing a transformation programme around having transitional care service within our postnatal ward, and this makes sure that we're actually improving services for mums and babies, so that we're not separating mum and baby if baby's having to go to special care. So there's lots of work going on with the team, and we're hoping that we'll be able to launch transitional care in April. We've also been undertaking a lot of work around our neonatal cot capacity. We know that the West Midlands Natal Network are looking to reduce cot capacity, but they've been looking at figures from around 2021, looking at numbers of cots that have been utilised across the system as well as at SWFT. So we're doing our own piece of work there to look at that, because actually we know that our increased birth rate is going to put increased pressure onto our neonatal cots. So we need to make sure that we know what our numbers are looking like. We continue to work on concerns around our postpartum and hemorrhage rates, and we know that actually they are down in December. We're continuing that work, and we've also been looking at our 3rd and 4th degree tears, because we've noted that they've just gone up slightly in the last 6 months, so we're just doing a deep bit of work around that. Sadly, in the quarter, we had 4 stillbirths and 1 neonatal death. We've ensured that we've provided support for those bereaved parents and to families and for the staff involved. And we've reviewed every loss to make sure that we get any learning that we need from those. But just to reassure the board, our rolling stillbirth and neonatal rates are below the national average. In December, as Ellie said, we had a 0% vacancy rate for midwives and maternity support workers, and actually that is not what the national picture is, and it's really great that staff want to come and work here. As discussed at the December board, we submitted full compliance for our CNST maternity incentive scheme, and that has now gone to NHS Resolution. We're just waiting confirmation of that, but well done to the teams. We're working really hard on our Saving Babies Life version 3 compliance, which is currently 89%. Actually, we know now to get that last 11% is going to be actually really difficult, because some of those areas are outside of our control. And one of those areas is around our current smoking cessation service, which is commissioned by our local authority and provided by SWFT Health Visiting Services, who do not sit in-house within maternity services. This current pathway supports a recommended practice that all women with elevated carbon monoxide level of preferred are referred to the opt-out stop smoking in pregnancy services, however, does not meet the in-house definition as outlined in Saving Babies Life version 3. So as the service is county-wide and is a very successful programme, the service will not be changing its current provision, and so a divergence from guidance needs to be submitted to NHS England to allow the continuation of the service in line with Saving Babies Life guidance, and so that we're not penalised as an organisation for having a service that's working really well but not in line in-house. So as you'll see in Appendix 2, there's a divergence that's been outlined by the LMNS in conjunction with SWFT and our other colleagues across the LMNS to be submitted to NHS England. And we just ask the board's approval that they're happy for that to be submitted on behalf of SWFT, that we can actually say that we've got a divergence to that. That's all I'd like to bring out of that report at this time, but happy to take any questions, Chair.
Very comprehensive report, Lorraine. We'll come back to that requirement for board approval on Appendix 2. I'll allow others to go first. Glenn? I
love it, Lorraine, that you say that's all you want to bring out of the report. There's so much going on in there. It's such a fantastic service. In fact, and it's all the things that go on around it. Like last week, we celebrated 10 years of having a local tongue-tied service, which has increased breastfeeding initiation. So there's just a fantastic team doing fantastic things. In the middle of all of that, you talked about, obviously, increasing demand through local population, increasing demand through choice, increasing complexity. Yet there's a discussion about reducing the amount of neonatal cot capacity. Personally, I find that rather bizarre. I know you do. I'm just flagging that with the board, that it's something that we need to ensure is looked at properly. We don't end up making the wrong decision that compromises local services.
No, I think that's absolutely right, Glenn. I know, and I'm sure David Spraggett, who's the other non-executive director, maternity champion, will endorse this. One of the real pressures the team has is the issue of choice. People from out of county choosing to come to Warwick for their babies to be born, which is a wonderful endorsement of the confidence they have in our maternity services. But when we are under so much pressure, and there are so many houses being built, I mean, Richard Collins just put into the chat box about relocation of both Shottery and Lighthorn schools to double capacity given the extra housing being built. There is a real need for us to not only continue to invest in the maternity team that we've got, but also to say to people out of county, unfortunately, people in Warwickshire, South Warwickshire come first, and I think we'll be needing to move to that over the next year. Be interesting to get David's perspective on that when David comes in. Charles?
I was going to say something very similar. I mean, first of all, what fantastic work we've heard about. You know, it's a brilliant service, and you're almost victims of your own success because people so much want to come and, you know, have babies in Warwick. But it also comes back to what we were saying earlier about lack of PBR, because we're doing this work, we're not getting the income, and there are step costs as well, that when you get to a certain level of activity, you have to start doubling up on some of on-call services. So I think we may well get to a point that the chairman has just mentioned where we have to put a limit on who we can take for protecting that fantastic service you're delivering.
Yeah, we mustn't allow the safety and quality of services in maternity to be diluted in our understandable desire to meet demand, but we just don't have the capacity. David, your view as chair of the Clinical Governance Committee, but also a long-serving GP in the community?
Yeah, I mean, some people have said many of the things I was about to say, but as you'll note in my Clinical Governance Committee report, I've flagged at least 2 of the last 3 months the potential risk associated with the rising popularity, shall we say, of maternity services. And I think that we're close to the point where as a board we need to take a view on this, because it's almost becoming too popular. I mean, when Russell and I visited antenatal clinic only last month, we were told there was 400 bookings, which if they translate to deliveries is, well, I think I work it out, that's later this year. There's going to be some months where we're going to have an awful lot more than 300 deliveries. So we're close to the point already where safety is going to be compromised. And we've got to work out how we deal with that. I presume, I know you're thinking about how to deal with it, but we do need to perhaps have board awareness of this.
Well, I think the discussion now is making the board awareness of it. Angela, I'm sorry, I'm a little bit pushed for time now. But what I'd like is under the Clinical Governance Committee sort of process to address this issue and get input from Charles, Angeli, Ellie, Fiona and others about when it should be, when we do need to we need to ensure, a bit like a surfer, we need to be on top of the wave, not drowned by the wave. And my worry about that 400 number that you and I heard, David, was we would drown in that, and that would have a consequence for safety. So it's far better for us, given we've got a lead time, as we know, to babies arriving, about what, and you and I have both asked for this, David, and I know Lorraine, Becky was working on it with others, about what our safe capacity is, and we manage to that safe capacity. Can I ask that to be taken away by clinical governance?
Yeah,
and over
certainly.
the next month to come back to board, because I don't want our wonderful services to be compromised and, like you said, Charles, be the victims of our own success. Sorry to cut you off, Angela, but I'm a bit pushed for time now. Really good discussion. Thank you, Lorraine. Thank you, everyone, for your hard work. We'll move on then to the Freedom to Speak Up Guardian report. Sue, lovely to see you.
Thank you, Chair. I'll take the report as read as usual. I think the hotspot areas for us kind of mirror the discussion you've just been having about capacity. So a lot of the patient safety concerns and staff safety concerns we have coming to us are around capacity, staff not feeling able to deliver the care they would aspire to give. And our hotspot areas mirror what you've just been saying, maternity, health visiting, children's services, community services as well. There's a high level of activity still within the organisation. People coming to speak to us and using us, I suppose, as a sounding board as well. So we get a lot of queries around policy application, service change, all sorts of things where staff are maybe not sure whether they've got a valid query, so they come and talk to us before putting their foot in it with managers, so to speak. The team have been really, really busy delivering lots of training Civility Saves Lives training has been going on since 2021, and we're just looking at ramping up our provision of that around a e-learning package as well. So we will pinch with pride work that's out there and being done by other organisations and make it even better and bigger for ourselves. And we are continuing to support managers through the toolkit and the induction programme as well around civility. And we've also been delivering more around microaggressions and privilege, which works on the stuff that we did as a board a couple of years ago with Kavita and NHS England, and just trying to highlight where behaviours and attitudes could still be better to support that psychologically safe environment for people to speak up. And we've also got coming up, or we're actively doing at the moment, our review of the reflection and planning tool. So we'll be speaking to all of you probably at some point about your roles and get your thoughts on that reflection tool. And Adam has kindly invited us to attend a senior leaders session in April as well, so we'll discuss that a bit more there. Other than that, happy to take questions.
No, great work going on, Sue. I love the pinch with pride comment. I will pinch that with pride and use it in other meetings now. Any questions or perspectives to Sue? Sue?
Yeah, hi Sue, thank you for the report. I just wondered on the page around the top themes for speaking up being around policies, processes and procedures, and those being typically around recruitment, sickness, absence. So our kind of big move of being a flexible worker. I just wondered, a flexible employer, sorry. I just wondered whether you have links in to make sure that our staff training on those points is being accessed. So if we've got middle managers who are perhaps not delivering the service out to their employees that we want, are they accessing training which is dynamic on that?
Yes, I think so. So I link in with Gertie and the operational people and workforce team, so we know where our hotspot areas are, or if there are particular examples where managers have maybe not been as flexible as they could, or where there's been some sticky points around reasonable adjustments. And then we work with people like Matt Clarson and the Disability Network, or with our other staff networks as well, and just make sure they've got those cases and those examples to learn from. And in my staff side role, I know I'm stepping down from that, but we've also made sure that staff side reps are affiliated with that training and try and make sure that there's best practice and learning. Obviously you can't force a horse to drink, but you can lead it to the water, can't you? We're trying.
And Glenn?
Yeah, another element of that staff survey that I'm not allowed to talk about today is a question that they asked staff about whether the organisation will act on freedom to speak up issues, and it's jumped quite nicely year on year, and a lot of that is down to the work of Sue of keeping us real to that promise and being like a dog with a bone on some of the issues that we need to tackle as an organisation. So thanks for your work on that.
No, absolutely, Glenn. The combination of you and Deepa and everyone in the network, so it's something to be really proud of. So thank you very much. If colleagues are happy to move on, in my incompetence, I failed to get board sign off of Appendix 2 of Lorraine's maternity report. Apologies for that, Lorraine. Thank you for reminding me. If you're not happy to approve that sensible adjustment, could you please raise a digital hand? Okay, that's been duly approved. Thank you, Lorraine. Hopefully that achieves what you wanted to. So we'll move on, and if I can just ask execs to pick up the pace a little bit because we are running late now. On the 7-day working annual compliance report, Charles?
I'll be brief. First of all, I'd just like to point out that there is an error in the paper that I did correct on the draft I saw, but somehow it hasn't got through to the papers, which is at the last box in terms of services available, thrombolysis, stroke, etc. They are available through a network. So there should be an X in those boxes. But overall, you can see, an improvement in our 7-day coverage, and in terms of standard 2 performance that is considerably better than what is seen nationally from audits. and an improvement in weekend cover for some of the medical wards. So all in all, I think this is a reassuring position, and it relates to our ability to flow at weekends and achieve what we do in terms of urgent care. It's one of the underpinning parts of it.
Thank you, Charles. Any questions or perspectives to Charles? Glenn?
I'll just say today what I said yesterday in the George Eliot board, because the data's almost identical, Charles, in terms of the number of discharges by day of the week. Friday's always the highest day, Sunday's always the lowest day. So there's still an opportunity for us to show a smoother picture because the demand is smoother.
Yeah, indeed. And the more we can even out, the better. I mean, there is the problem, as it says in the report, that sometimes the services to allow discharge, particularly for our sort of elderly patients, just aren't there in the same way on Saturday and Sunday.
Okay, Charles, I'll just ask a specific question, and it does relate to that last box, which is stroke services over the weekend. From a system perspective, if I had a stroke at the weekend, or you have a stroke at the weekend, how good would the stroke services be at the weekend?
Well, the stroke services is at UHCW, and part of the centralisation was that they do have a stroke team to provide 24/7, 7/7 service. The slight weekend issue is that thrombectomy services are not available at the weekend at UHCW, only apply to a small number of patients, and they would then have to work with the QE. In fact, thrombectomy is not being performed in any large numbers in UHCW anyway. It's a service that is really only just developing, but that would be the major difference.
Okay, and sorry, just for the uneducated amongst us, I include myself, what is a thrombectomy?
This is where you're using a interventional radiology procedure to actually remove the clot that's in the arteries supplying the brain, and it's a relatively new technique. It's rather like PCI for acute heart attacks, unblocking the vessel mechanically, and there is a window that are up to 24 hours to do that. But it's a high tech, high skill procedure that's difficult to provide because of the manpower.
But the QE does provide that service over the weekend.
Yeah, they do.
Okay, great, thank you. I remember that. Tell the life. So we'll move on then. Thank you, Charles, to the capital programme quarterly update. Sophie.
Thank you. So we've got two good news. We've got two of our integrated projects coming online this year in April and then September, which is the Lillington Hub and the Ellen Badger Hub in Shipston. Both of those are really aligned to our big move around prevention and that partnership working and that shift in terms of our community estates. It's really great that both of those are now on track to complete this year. The demolition has started. I can't give this update without talking about the elective hub. So the demolition is about to start. I've realised I can see it from my window, so I'll be keeping an eye on it. But alongside the elective hub, in the last few months, we have seen opening new facilities for cardiac teams, oral and facial department, and this month for the gynae team. So in themselves, they're really big projects, but they're part of the elective hub, and it's just taking note of those here that this project has enabled a lot of new facilities to come online for our teams. And then the final thing to point out is there is slippage in spend, which Kim and I and others are looking to mitigate through the financial strategy that Kim's leading. I just want to point out to board that actually one of the biggest things has been costs that have come back throughout the year have been much higher than our anticipation. So I think moving forward, we need to plan to have that value engineering process in when we're forecasting, so that we have like a worst case scenario and we can bring it back. But every project we've done this year has come in over what it should be, and the teams have then had to work to really sort of value engineer that down to a place that we're comfortable with. So just a bit of learning there as well we'll take into next year's capital programme. Yeah, no,
Sophie, I think you and the team are doing an absolutely outstanding job juggling all of these balls whilst Harcomel, and I'll focus on Harcomel, still manages to run the engine of the acute. I think it's quite phenomenal the work you're doing between all your teams. Glenn?
Yeah, thanks, Sophie. On the value engineering point, I agree that we can bring some options in on that early on, but is there some learning here for our QS on the way that we're costing projects?
It's a good point, probably, but I think there's just some learning about our standards as well, and exploring different construction methodology, exploring different things that we've never done before, and stretching ourselves. Really, it's more around that, and just rising cost of materials. And we often get those warnings from the QS, but we push on anyway. So there's some learning for us on that, I think.
I think that's a really good challenge about thinking differently about solutions and building solutions, Sophie. Okie dokie. So if we have no questions more to Sophie, we'll move on then to the report from the Council of Governors meeting held on the 15th of February, which I'll take as read. But again, thanks to all of the governors for the work you do on a daily basis, being representatives of different stakeholder groups, but particularly citizens. The amount of different subcommittees we have on the Council of Governors and working groups is quite extraordinary. So thank you to all the governors. Any questions on that report? So we'll just move on then to the Audit Committee reports on 13th of December and 14th of February. Richard, anything you want to pull out on these?
No, I think take them as read, please, because they're quite old, but I think we've talked through the issues. So thank you for everybody's support on that. So I think the main thing to say is that we've reached agreement with Deloitte on the fees, and also ways of mitigating any cost escalation this year.
Okay, great. Thank you, Richard. Any questions to Richard? And in a similar vein, the clinical governance reports of the December, January and February. David, anything you'd like to pull out?
Nothing other than that I've already pulled out regarding maternity, so take it as read.
Thank you. Any questions to David? Okay, we'll move on then to risk management and the board assurance framework and risk quarterly report. Adam, what do you care to pull out on this?
Thank you, Chair. Just to note, the report includes an update to our board assurance framework, which includes the strategic risks to our trust objectives. You'll see a number there have been closed and some updated. The report also includes the red risks on our divisional risk registers, which have been reviewed and updated through Risk, Health and Safety Board, which meets quarterly. I'll take the rest of the report as read, but happy to take any questions.
That's great, thank you. Any questions to Adam on the BAF or the risk quarterly report? I hope members of the public can sort of gain a flavour of the enormous amount of governance work that goes on behind the scenes that the executives have to handle. We'll therefore move on to items for noting and information. The summary of ratified policies. Again, Adam, over to you.
Thanks. Another detailed item of governance, Chair. So the report reflects policies agreed by Policy Review Group in December and February. There was no meeting in January, and there are 15 policies that have been approved, generally updates to existing policies as part of our usual work.
Okay, super. Any questions to Adam on the ratified policies? Okay, thank you. So we move on then to the Guardian of Safe Working. What an important role that sounds like, a Guardian of Safe Working annual report. Charles.
Yeah, and I think there is a safety aspect here, is that, you know, a very overtired junior doctor is impaired as somebody who would fail a breathalyzer. So actually making sure that we stick to the guidelines in terms of hours and rest breaks is very important. You can see, again, there's a lot of governance underpinning that. with exception reporting. Our exception reports, this is when doctors work beyond their hours or other issues about their education, are relatively small. They're addressed by the Guardian of Safe Working and the team, and I think that is all working well. One point I think I would make from the report is you'll see that we have quite a lot of vacancies where we're expecting doctors to be placed from Health Education England, formerly known as the Deanery, and that they have gaps, which in turn puts pressure on bank and agency. And as part of the bank and agency work, you will also see that we have become a GMC affiliate to be able to help bring in doctors from abroad and take them through the regulatory process and help fill these gaps. And we want to build on that and look after these doctors. Another area where we're looking after a workforce, we've extended these processes for our trust grade and other grades of doctors, so everybody's covered. We don't have to do that, but we felt it was good practice and have.
No, great, thanks, Charles. And any of us who have read the book, This Is Going to Hurt, will understand Charles's point about tired junior doctors in particular. Any questions to Charles? Okay, thank you, Charles. And we'll move on then to the update of directors' interests. Sarah?
Thanks, Russell. So this is just for noting and information, but just to make the board aware that we're going through updates of declarations of interest as part of the annual process, which will be reported to the board next month. So just a reminder, if you haven't already updated your declaration of interest form, please can you do so and submit to me. Thank you.
Okay, super, thank you. Any questions on the declarations of interest? Okay, thank you very much. And then before we move on just to the board committee minutes, the audit committee of the 11th of October and 13th of December. Richard, anything you wanted to add to this?
Sorry. No, nothing to add to it, so take it as read, please.
Thank you. Any questions to Richard? And thank you. And then in a similar vein, the Clinical Governance Committee of the 8th of November, the 13th of December and the 10th of January. David, anything you'd like to add to this?
No, nothing to add.
Thank you. Any questions to David? So I think board, we're on to any other business. Any other business from members of the board? Okay, can't see a digital hand raised, so we'll move on then to questions from governors and members of the public. Sarah, I think we've had a couple. Would you care to read them out for me, please?
Thank you. So the first is from Roger Lloyd. Roger says, does the trust expect to eliminate the 65-week waits in the elective division by the 31st of March this year? And with what certainty? Similarly, what is the trajectory for the 52 weeks wait in 2024? I think Harkamal alluded to some of this earlier, but if she wanted to answer that question, thank you.
Yeah, so just to reiterate that we won't eliminate the 65-week breaches for orthodontics, and that's been flagged in all of our returns. With regard to the 52 weeks, we are working to clear that backlog, and we have seen improvements. We are mapping out a trajectory, but until we've seen the planning guidance, I haven't set out what my expectation is going to be around the speed within which we're going to do that. But just to provide assurance, we have seen a steady reduction in our very long waiters.
No, thank you, Harkamal. Glenn, did you want to come in on that answer?
Yeah, and just to be clear on the national expectation, which is that we will have eradicated 78 weeks by the end of this year. It was adjusted in year because of the impact of the industrial action. So the 65-week position that we have has been reported and is within the expectations of NHS England.
Yeah, no, absolutely. And the second question, Sarah?
Thank you. So Mike Wells has asked that in December 23, he asked if there was anything the Trust could do to help the availability of out of hours palliative care drugs. speaking to local palliative care organisations. This is definitely an issue, and Mike wondered if there was any change or progress. Harkamal, I think you're going to answer this one as well.
Yeah. So just to clarify that we do have a process to provide access to palliative care medications out of hours, and that's in place both at SWFT and at the George Eliot, and it has been in place for a number of years. It's quite historic. There may be a risk that the patients don't all know about it, as it's not open to the public in that way, just around lone worker requirements. But the palliative care teams know, and our community nursing teams know, and our primary care colleagues know. So it would be really helpful if I could just have a few examples of any of those organisations who are struggling, and then we can provide some support to them. The system also has support, so we are supporting the system with reviewing the new contract to work with our community pharmacy teams to be involved in providing medication out of hours to those patients as well. There's quite a few actions around just making sure that the governance is robust. Just as a reminder, 90% of palliative care medications are controlled drugs. So we just have to be mindful of the legal implications and the boundaries in which we can sort of operate to provide support. But the palliative care teams are aware. So just to plea for any further information, and then I can work through some of that detail.
Okay, I guess, Harkamal, it would be good if you and I can maybe take it offline.
Yeah.
It's always been my view that, you know, in today's world, it shouldn't be the case that anyone should die in pain.
No.
So it's just making sure on that nightmare 2 o'clock in the morning on a Saturday night, your loved one's at end of life, you're at home, that they're in pain. How do we, does everyone know where to access pain relief in that scenario? If maybe a combination of you, David, and I could have a chat, and if Mike wants to get involved, about thinking about some patient stories and real experiences where the system, if you like, we might have the protocols in place, but at 2 o'clock in the morning, a family member doesn't know what to do. It's that type of scenario I think Mike is alluding to, which in those type of circumstances, it's a desperate situation.
Yeah.
Thank you, Harkamal. We've got a couple of minutes. Any other members of the public who would like to ask a question? Could you raise a digital hand for me? Okay, I can't see a digital hand being raised, so I will draw the meeting to a close. Always feels a little bit like an auctioneer bringing down the hammer at that point, and look forward to seeing you at the beginning of April. Sarah, can you remind me on the exact date?
Yep, sorry, Russell, it's the 3rd of April.
Look forward to seeing you on the 3rd of April, same time, same place. Thank you very much, everyone, for your hard work. For board colleagues, I suggest we have a 10-minute break, get back together again at 3:45 for the confidential board. Again, thank you very much, everyone. Take care.